Yeah. All right, guys. So moving from RSI, we're going to talk about complicated airway management. Again, here's some disclosures. Make sure you follow your local protocols and guidelines. There is going to be another QR code at the end of this for CEs. You should not see any biased equipment or anything in here. I'm not making any money off of it, unfortunately. Here's your objectives. Talk about some causes of common difficult airways. Some of this is going to be a repeat from the RSI lecture, but we will talk a lot about positioning the airway. There's going to be a little bit more in-depth talk on these various things here. When they talk about safe apneic time, basically what we're talking about there is, like we said earlier, pre-oxygenating the patient well so that during that time while they're not breathing or they're apneic, you have an increased amount of time that they stay oxygenated to get that airway in place. All right. So difficult airway, this is just kind of a definition of that. Here is a clinical situation in which there is an anticipated or unanticipated difficulty or failure is experienced by a trained provider while performing the airway intervention. And we're going to talk about the various parts of that. We'll talk about face mask ventilation, laryngoscopy, the intubation process itself, and then some supraglottic airways that may or may not work for you, and then ventilating the patient. So these are the three different things that are going to cause you to experience a difficult airway. It can be some kind of an anatomical problem, whether that's just their anatomy is a little bit different than normal, or it could be that there's something obstructing that anatomy to where you're going to have to work around it. There could be physiological changes in the patient. Again, we've talked a lot about resuscitating them if they're hypoxic, if they're hypotensive, if they've lost a lot of blood, various things. And they could have a tension pneumo, something like that. And then since situational is just that, it's situational. Maybe your patient's in a precarious position and you're awaiting extrication or something like that, that's going to make getting their airway secured difficult. So some anatomy things. If they have a limited mouth opening, and again, we talked in the last lecture about the 332, that's what we're looking for there. If they have limited ability to open their mouth, that's going to cause you some difficulty. If they have a large tongue, maybe just normally they have a big tongue, right? Or they could have tongue swelling, like you're seeing in this photo here. Obviously, that's going to cause us a problem, right? Neck mobility, talked a lot about that. Anterior anatomy, we'll talk a little bit about how you can mitigate that and some things that might help you get that airway into view. They could have some kind of a mass or obstruction, and we'll talk about how to deal with those. And then they may just have congenital defects or some kind of a anatomic anomaly. I have seen some very odd anatomy in my career. So this does happen. And you just got to be be ready for it. That's why it's so important to know your anatomy, the different structures, and things to look for, because you may not be able to see all of them. This is going to be a review from the last PowerPoint talking about the Mallampati score. Does have a little bit different pictures than the last one. Obviously, we want them to be, it says class 3 or better, but preferably class 2, right? Almost never get a class 1. So just be aware of that. Here's your 332 rule that I was talking about earlier. This has a diagram that shows that a little bit better than probably I explained it. But it's a scoring tool just like most other things. This is showing you, again, how they can open their mouth, whether or not their airway is going to be anterior or superior, and including neck mobility in that. Some anatomy again. There's that ligament that I was talking about that I couldn't remember the name of. It's the hypoepiglottic ligament, which is responsible for raising your epiglottis when you get your Mac blade into that vallecula. That's what's going to lift your epiglottis up for you. On the right there, again, make sure that you can identify the arytenoid cartilages. The intra-arytenoid notch is generally where your tube is going to rest once you get it in place. This is kind of a good picture because it shows how those true vocal cords are not necessarily pretty white like we always see in pictures and we see in our airway heads that we practice on. A lot of people have gotten to where if they can't see that, they don't think they're in the right place. So again, make sure that you know the rest of that anatomy in there and be looking for those. This is just another scoring tool that we use. Don't get too hung up on these scoring tools, but this is just to kind of help you document and predict difficulty in getting an airway in place. On the bottom there, as you can see, like I said earlier, you almost never get a grade 1. They're saying less than 1% of the time. I'm sorry, less than 1% of the time. If you have that, it's going to be an easy intubation, right? But usually see that 68 to 74% of the time. Grade 4 is pretty rare, just depends on what that patient has going on. But we don't want to see that, right? All right, as far as managing difficult airways, these are the things that we're going to be talking about. We're going to talk about patient positioning. We're going to talk about optimizing that safe apnea time or optimizing pre-oxygenation. Talk more about video laryngoscopy. Excuse me. Bougies, alternative airways. And then we'll also talk about external laryngeal manipulation, which you probably know as crike pressure. There is a little bit of difference in those two, and we'll talk about that. This has some great pictures on patient positioning. Elevating the head of the bed. You know, if you've got this patient on an ambulance stretcher, it'd probably be easier to just sit her up, right? To elevate that head of the stretcher. But look how many sheets and blankets and towels and stuff they got under that.
Is there a step ladder in that picture? Above enough?
um, yeah, so and that is something to think about. You know, if you have to sit a patient up like this, you may have to lower your stretcher down just so you can reach to get the laryngoscope in her mouth, right? So don't forget that. You heard me talk earlier about having their ear in line with the sternum or the sternal notch, and that's what they're showing there on the right. This is this process is known as ramping. I just call it elevating the head of the patient. All right, this is that hemoglobin desaturation curve that I talked about in the last lecture. This is why we want to pre-oxygenate our patients, and it kind of shows, like I said earlier, how they fall off the cliff once they get below a certain level. And the blue line there is a normal 70-kilo adult. So we've got some time there, right? Shows, you know, as much as 5, 6, 7 minutes, 8 minutes even, before they fall off that cliff. But once they hit that spot, they fall off drastically, right? All of them do. And that's why we want to keep them above 93. The reason for the 93 mark is also due to what's known as SpO2 latency. And what that is a delay in the readings that we're seeing on our SpO2 and what it actually is. This varies by patient, but it has been shown that there can be upwards of a 2-minute delay in the readings that you're seeing and what your patient's SpO2 actually is. So that's why we shoot for that 93 mark. Notice the green line there is for a 10-kilo child. Not going to have as much time with those as we are with a normal healthy adult. And even less with our obese patients. Apneic oxygenation, or what I like to call passive oxygenation, just because it sounds better. But that is a continuous flow of oxygen during that apnea phase after we have sedated and paralyzed them. They're no longer breathing on their own, and we are actually getting ready to start the procedure, right? We can't ventilate them and intubate them at the same time. So we want to keep them oxygenated during that time. The best way to do that, again, you know, if they're breathing on their own, put a non-rebreather on them. But you can put that cannula up underneath there, hook it to a separate source, and turn it up to 10, 15 liters. Again, that oxygen will get down into the lungs and the airway and diffuse and participate in gaseous exchange and extend our time that we have to get that airway in place. And this kind of shows on the bottom right there the differences in time with and without passive oxygenation in place. There it goes. This slide talks about SpO2 latency and that lag time that I was talking about. Typically 30 to 90 seconds, but again, there's some YouTube videos out there where they purposely desaturate patients and kind of show the lag time in the monitoring devices. Again, we don't want them to fall off that cliff, right? So that's why we stop at 93% and reoxygenate them. We talked a lot about video laryngoscopy in the last one, so I won't go through that again, but this is a very valuable tool specifically in the difficult airway. I have had a few patients since we got these that I'm not sure would have been as easily gotten without the video. Bougies, again, these are pretty popular. There are several different ways to use them. This picture shows preloading the tube on there. There's pros and cons to that. They had us doing this for a while, but what we found is that it's incredibly top heavy with that tube on there and coiled over like that. So it's constantly wanting to twist one way or the other when you're trying to get it in place, especially if your hands are bloody and or got vomit on them or whatever. It can be difficult to do that, but most of the time I find that it's the easiest thing to do is just place the bougie and then have your partner slide the tube over the bougie, and then you can slide it into place. Now, this is an actual video with CMAC and putting the bougie into the airway. Sliding the tube over top. External laryngeal manipulation is something that can help you, specifically if you have patients that have an anterior airway. This is something that you kind of have to practice this, but if it's not done correctly, it can actually hinder you. So practice this with your partner on your airway heads. The biggest thing that I find is that, you know, they used to call this crike pressure. Well, most of the time people put their index finger and their thumb on the thyroid wings or cartilages on the airway and push down. It's not thyroid pressure, it's cricoid pressure. The cricoid ring is down below the thyroid structures there. And basically what you're wanting to do is push down on that lower portion. And what it does is it rocks the airway up with the hope of bringing it into your line of sight to be able to put the airway in place. And you may have to, you know, move your hand around. A lot of times it's better if you do this yourself, the person that's intubating the patient, if you do this yourself, because you can tell what's working and what's not and reposition your fingers into the right place. We talked a lot about this already, but this is just kind of showing percentages of first pass success for neuromuscular blocking agents. Alternative airways, again, most services are carrying some form of either a LMA, King. What do you guys have again? Eye gels. The eye gels are pretty popular. And then we'll talk about cricothyrotomy, surgical and needle crikes, and then nasal intubation. I would encourage you, if you don't already, to put together some kind of a crike kit. You don't necessarily have to have a commercial kit, but if you have the protocols and guidelines to be able to do that, put a kit together. That way you've got everything in one place, that you can grab that if you need it. We talked about the Heaven criteria for predicting difficult airways, and some ways that you can mitigate those. Again, if they're hypoxic, a direct might be faster and a little bit more straightforward. You're not going to have as much time with those, right? And even patients that you've pre-oxygenated and have passive O2 in place, sometimes we just can't get them up over that 93 mark. And at some point you have to make the decision, okay, I got to go ahead and do this, but I'm not going to have as much time, right? So it is something to keep in mind. Extremes of size, again, video might be better for those than direct. And it talks about those different things there. I won't go through each one of them, but this is a pretty valuable tool just to make you think about what's going on and how you're going to mitigate that. As far as physiologically, we talked about, if they're hypoxic, we want to reoxygenate them, right? If they're hypotensive, we want to work on that. If they're hypovolemic, we want to work on that. Make sure that we're resuscitating them to set them up for success. We want to avoid that peri-arrest situation and keep them from coding on us during or shortly after the intubation. Again, don't forget your basic airways, your OPAs, NPAs. If you haven't used those in a while, get them out. Practice measuring and inserting those. PEEP valves, again, these come on a lot of BVMs now. You can also buy them separately and put them on there if you don't have those. Using the 2 thumbs up technique to get them oxygenated, and then getting your apneic oxygenation in place. And it's been shown that we should be spending several minutes, 3 to 5 minutes doing nothing but pre-oxygenating the patient prior to RSI. And that sounds like a long time, and it is, but it is very beneficial for the patient and their outcome. This one talks about extremes of size. Again, this is both large and small. With our little kids, their head's bigger than their body, right? So you may have to pad under their shoulders. Talks about getting them in that sniffing position. Again, ramping. Use what's necessary. Pillows, blankets, towels, whatever you have available. And then this is where your video laryngoscopes are going to be very valuable to you. Anatomic disruption or obstruction. Again, make sure you've got McGill's in your airway kits. Never know when there's going to be something in there that you're going to have to try to grab and get out of the way. This is also where it's important to have different size tubes available to you, out and ready to go. And then, of course, your alternate airways. You may get in there and it be completely obstructed, and you're not going to be able to get an airway past. You may need to put an alternate in there and ventilate them that way. Vomit, blood, or fluids in the airway. Again, this is where we're talking about suction. Make sure you have this. Again, it's hooked up, turned on. Test it. Make sure it's actually sucking and that it's got significant or adequate suction. I had a situation recently where I did an RSI in a hospital using their suction, and it was not very good. I mean, it just wasn't pulling very good suction, which was frustrating, but I made it work. The salad technique. is just a fancy acronym for continuous suction. SALAD stands for Suction Assisted Laryngeal Airway Decontamination. Again, just a fancy mnemonic for continuous suction. And this is where, you know, we've all had these patients where you suction them out, then you set the suction down, grab your tube, and before you can get it past, their airway's full of vomit again, right? And you just keep going, and you keep doing that back and forth. This is something that you can do that will help you in those situations where you place the suction into the airway and basically leave it there. A lot of times I'll put it on the back side of my left hand so that it's out of the way, but it's constantly in there pulling suction. Some people will actually take the decanto upside down like it shows in this picture, and they'll actually push it all the way down into the patient's esophagus. Reason for that is that's where it's coming from, right? Usually that's where your vomit's coming from, and it's going to obstruct the esophagus, so you're not putting the airway in there. This works better with a decanto suction catheter, and basically what that is a little bit bigger. It's got a larger diameter lumen inside of that hard catheter tip there. It will pull a lot more fluid and chunks, if there's that is in there, than say like a Yonker would. So if you don't have these, I encourage you to look those up. I'm not sure if there's any other brands of suction catheters out there, but the Decanto does work very well. Exsanguination, this one's pretty self-explanatory, right? If they're bleeding out, we need to stop that by whatever means, so make sure you have tourniquets available. Don't forget, you know, direct pressure and simple things like that too, but if they're exsanguinating, we got to stop that, right? That takes priority over the airway. We got to stop the bleeding and then hopefully replace it. Give them some fluids. Blood products, if you have them, is even better, and try to get that, refill the tank, and then we're going to talk about squeezing the tank or putting pressers on them, push dose pressors, to get that pressure up so that they don't coat on us. Neck mobility, again, this has a lot to do with positioning the patient, opening that C-collar. It is a little bit gentler on the C-spine if you use video laryngoscopy, because you don't have to raise that airway up as high as you do with direct laryngoscopy. Situationally difficult airways, again, you know, if your patient's entrapped, this shows talks about blind insertion, but the picture there is showing a face-to-face intubation, or what some people call tomahawking your patient. Be careful saying that, because people think you're actually taking an axe to your patient. But I have done this before, and it is somewhat difficult to do. The last time I did this, the patient also had a complete Lefort fracture. And so all of their upper palate and teeth, whenever I would pull down, everything would just fall down with it. And so I actually had to have somebody help hold that top palate up out of the way so that I could see what I was doing. This is something that, again, you got to practice, but it's basically just doing an intubation upside down, right? You're face to face with the patient. You've got to pull down instead of lifting up, and you're trying to look over the top down into that patient's airway. Again, this talks about when to call a helicopter. If you need more hands, we do have two more people to help in these situations. We do have video laryngoscopes if you need that, blood products, and we do have a fairly high first pass success rate. So we're there to help you guys. We're not there to take over. We're there to help. So, in summary, there's multiple anatomical and physiological factors that can make an airway difficult, and you just got to be thinking about what's going on with that patient. You know, if it's a burn patient, I'm probably going to see swollen, burned anatomy, right? And burn patients can be some of the most difficult patients to intubate because not only is everything swollen, but it's burned and black and charred, and you may not be able to see vocal cords at all. So again, it's important to be able to recognize the different airway structures so that you can get it in place correctly. You may have, I've intubated patients who had no face at all. I had a patient one time that blew his face off with some dynamite, basically from the ears forward, his jaw, both eyes, nose, mouth, everything, tongue, everything was gone from basically the ears forward. And on that one, sometimes you just have to look for the air bubbles, right? Interesting thing about that particular patient is all of this airway anatomy was still intact. And it was actually a fairly easy intubation. The problem with something like that is, how are you going to ventilate them prior to the RSI, right? There's no way to put your BVM on them, so you're going to have less time. The other problem is, once you get the airway in place, how are you going to secure it? I ended up just taping the heck out of it, you know, doing the old lasso tape thing that we used to do before there was such a thing as commercial tube holders. So again, it's important to keep up all those old skills and think about alternative ways of dealing with various scenarios. Make sure that you're doing proper assessment, screening them, you know, for those different difficulties, and the key is preparation. Take the time to prepare both the patient and you for success. There's the QR code for the CEs. How much time is left? Okay. I'm going to go back to the other one and talk about crikes. Okay, so surgical and needle cricothyrotomy. This is for those patients that we couldn't get an airway, right? Can't intubate, can't ventilate. The hardest part of surgical and needle crics is making the decision to do it, just to be completely honest. This is not something that we want to have to do, but it is an important skill that we have to be able to, as a last-ditch effort, to ventilate our patients, keep them oxygenated, and sometimes it's literally just temporary until we can get them to the hospital, right? I mean, it's not a definitive airway. It's a last-ditch effort. All right, the objectives. We'll talk about primary indication. I basically just gave that to you. We'll talk about 2 common causes of failed intubations, some age limitations for different ones, and some complications that you may run into. So indications are going to be patient can't breathe on their own. Like I said, can't ventilate, can't intubate, right? Patient cannot be oxygenated or ventilated by any other means, essentially. And if, you know, obviously if intubation is impossible. All right, so failed airway, and just gives you kind of a textbook definition of that. And some common causes. Some of it could be just that they're super anterior and you can't get things lined up where you can see them. Neck immobility, again, you just can't get things lined up. You can't get that airway positioned where you can see what you need to see. You know, blood or secretions in the airway, obesity. Some of these we've talked about and how we can mitigate some of those, but sometimes you may not be able to mitigate it, right? Major trauma to the airway itself specifically. Most of the time in these situations, your supraglottic airway is not going to work, right? Because again, if you can't ventilate them, typically with like an OPA or an NPA or any other kind of, the air won't, there's something blocking the movement of that air. Your supraglottic airways are probably not going to work, right? So surgical cric, and this shows what I was talking about earlier. You've got your thyroid cartilage, or what's commonly called the thyroid wings there, are the 2 big cartilages you see at the top. And then your cricoid cartilage ring is down there at the bottom. And like I said earlier, with cricoid pressure, most of the time this is done incorrectly by putting pressure on the thyroid cartilages versus the cricoid cartilage. But then you have the cricothyroid membrane in between those 2 landmarks. And you can usually feel this on yourself. The easiest way to do it is find the tip of what's commonly called the Adam's apple, or the tip of that thyroid cartilage. Slide your finger down the mountain, what they call it, down the mountain, and you're looking for the lake at the bottom of the mountain. So as you slide your finger down that thyroid cartilage, you'll feel an indentation in between the thyroid cartilages and the cricoid ring. That's what you're looking for. That's the landmark. Some people will take a marker and mark it just so it's easier to find the next time that once you get everything ready to go. Some people mark it just in case they need it. They know it's going to be a difficult intubation, so they go ahead and they mark the landmarks for a cric just in case they have to go to that. This is the ATLS preferred technique for doing a surgical airway. We used to do trachs, where you actually made a cut in the trachea itself, but they've kind of moved away from that, at least in the pre-hospital world. They do still do them a lot in the hospital. Sorry. For needle cric, the landmarks are the same, right? We're still looking for that cricothyroid membrane. The only difference is, instead of making an incision, we're going to insert a needle into that membrane. This is particularly useful for kids that are less than 8 years old. Most protocols don't allow for surgical cracks below that age range. You can do it on kids or adults as well, but it just doesn't work as well as a surgical airway. If you've never tried to squeeze air through say a 14 gauge catheter, hook one of those up to a BVM sometime and try to squeeze air through it. That's what you're going to be dealing with. It's literally a emergent last-ditch effort to get some oxygen into those lungs. You're also going to have difficult getting air out of that. So sometimes you actually have to unhook it and just squeeze their chest to get the air out. Again, it's a temporary measure. Not going to last very long, but it will give you time to get them transported. Some contraindications. Again, there's really no absolute contraindication if you can't intubate and can't ventilate them. Obviously, if you can get them intubated, that's a contraindication to doing a surgical crack, right? We don't want to just be doing this for the heck of it. It is truly an emergent procedure. Some relative contraindications would be if you can't find the landmarks. But I would tell you, if you're to that point, you're going to have to find them. I tell people all the time, you know, that a lot of people teach to make like a 1-inch incision. Make an incision where it doesn't matter if it's 2 or 3 inches long. Make an incision where you can get in there and find those landmarks, find the airway structures that you're looking for. You may have to cut deeper than what you think. You're cutting through adipose tissue. It is a highly vasculated area, so you're going to have a lot of bleeding. Be ready for that. In 25 years, I've only actually done this once. I've been in on a couple others that I didn't actually do, but I helped with. And I can tell you that one of the biggest things, one of the most helpful things, is to have somebody that has some like 4x4s or gauze of some kind, and have them pull slightly out on that incision as you make the cut, so it holds it open where you can see, and then just be constantly dabbing the blood off of it so you can actually see what you're looking for, because it does bleed quite a bit. And obviously we're talking about complications here, so bleeding is probably the biggest one. False passage is where you don't actually get the tube or the needle into the trachea itself. And this is easy to do. Sometimes you think that you're in the right place, but it's actually not. So if you're having problems ventilating them after you get that Shiley or whatever tube you have in place, you may have a false passage and you need to take it out and work on that. Vocal cord injury, that's something that may or may not be able to be avoided. Perforation of the trachea. Once you find the landmarks and you make that incision in the cricothyroid membrane, don't get too crazy. And it's easier said than done, because I can tell you your hands are going to be just shaking when you're doing this. So be very careful that you don't cut through the cricoid ring and actually cut down into the trachea. It can happen. You can get some subcutaneous emphysema, pneumothorax, aspiration. Those are all just things that kind of go along with it. Some equipment for surgical airways. Again, make a kit. You don't have to have all this fancy stuff. You don't have to have a commercial kit. Get some scalpels. We for the longest time we did not have trach hooks. We didn't have dilators. We didn't have bougies for a long time. We just literally made a cut and put the biggest tube that we could fit in there. We actually carried a 6.0 tube in our kit for a long time. The one that I did, I could not get a 6.0 tube in that cricothyroid membrane. The largest tube I could get in there was a 4.5. When we got that patient into St. John's, they were very critical of that, but I told them, hey, it's better than nothing. I mean, that's all I could get in there. And they can change it later if they want a bigger tube in there, as far as I'm concerned. But these are just various things that will help you. You know, that tray cook, once you make that cut and you get the hole, you want to make sure that you have something in there, whether it's the scalpel. A lot of people will turn the scalpel over and stick the handle down in there, or leave their finger in it. The tray cook is very good for actually hooking into that and holding onto it, because a lot of times if you let go of it, you'll lose it down in the tissues, and then you got to search for it again. The bougie, again, will just help you be able to get that tube into place. The Shileys work great for an actual tube. Just know that if you're putting a regular endotracheal tube in there, it's going to be a lot shallower than what it would be if you're putting it through their mouth, right? So the chances of getting too deep are pretty high. So just be aware of that. If you look at a Shiley, those things are not very long, and they've got a sharp angle on them. You can pass those over a bougie, though. So if you have the bougie, go ahead and use that. And then if you have some kind of a securing device, great. If not, just tape the heck out of it. On a needle cric, again, you're just placing the needle through that membrane. It helps if you have a syringe. Put a little bit of saline in there, and then be aspirating on that syringe as you put the needle in. When it gets where you have free air, you'll have a lot of bubbles coming up through that syringe. That'll tell you that you're in the trachea. At that point, you're going to kind of drop it down to a 45-degree angle, and then slide that catheter over top the needle, just like you would if you were doing an IV. The point being is you don't want to stab through the back side of the trachea, right? So we're looking for that free air, and we know we're in place, and then don't advance it much more than that. This talks about some different hub adapters that you can use. A 7.0 ET connector will go right onto a 3 ml syringe to be able to hook your BVM right onto that. And there's another one that will hook directly onto the IV catheter itself. However, I can't remember what size that is. I would encourage you to use the 3 ml syringe, though. It gives you a little bit more, because you got to secure that, right? So it gives you something to tape to and get it secured. And there's various cric kits out there on the market. I think some of the best ones are the ones that are homemade, personally. Again, this talks about identifying your landmarks. Find the Adam's apple, the wings, and walk your finger down the mountain. Find the lake at the bottom of the mountain. And that's where you're going to make your incision, kind of starting at that tip of the Adam's apple and just kind of cut down. You may have to make several cuts to get down to where you need to be, so just be ready for that. It's not a one cut and done type of thing, and it's going to be different for every patient, right? This kind of shows kind of what you're looking for on an actual patient there. And then you've also got to cut down on a cadaver there. It may or may not be as obvious as what you might think, but there is quite a bit of other tissues there. You see the muscles, stuff around that you've got to get through. A lot of connective tissue and so again, post-procedure, just like you would if you were intubating someone, you want to make sure that you confirm placement, right? So we're looking for breath sounds, our chest rise and fall, and then ultimately in tidal waveform. Again, secure it. There is commercial trick ties out there that you can use. A lot of people use oxygen tubing to tie around those. Tape works well. And then just make sure that you're oxygenating and ventilating the patient. Some chronic trachs, you might see these. Most of us probably have dealt with these in the past. Suctions can be super important. We do have some additional training available on this if anyone's interested. That's what I got for surgical and needle crack. Any questions?
Appreciate it. I do have a question about burns. So when you have a burn patient, typically the airway will shrink or swell.
Yeah.
Thank you. That's what I was looking for. It swells. Should you always typically go with a smaller ET tube?
I usually do.
Okay.
I usually grab a size, at least one size smaller than I would normally use. And
even if you think like, oh, I think this will fit, I'm still going to go with the smaller one.
Yep.
Okay.
Sure do.
You're starting to get the thank yous.
It depends. Some of it depends on how long it's been. Like if, you know, us on the helicopter, we're usually not the first ones there, right? We usually get there after you guys have had them for several minutes. And so that's another thing that I'm thinking about is there's been some time in between the time of injury until the time that I'm working on them. So, but I would definitely have some smaller sizes ready to go.
The thing you remember about burn patients is I've never had a burn center get mad because I intubated a patient. Have had them get mad because we intubated fast enough. So if you think there's airway compromise on a burn patient, intubate them. I mean, we've taken a vast amount of around burn patients to burn center. The very first thing they do is a bronchoscope and see if there's airway burns. And most all of them will say either yeah, we'll keep them intubated for a while, or if they say no, we're just going to extubate it. And we've even said around and said, well, sorry, we're kind of inconvenienced. And they said, oh no, we would rather do this as opposed to the other way because then you.
Time was okay.
All right, if you don't have any more questions for Scott, we're going to switch over and prepare for Nate.
I'm going to shut this down and give us a few minutes to sign out and sign back in.